Now, the next session is by David Francoz from the University of Montreal, and it's a systematic review of non-antimicrobial treatments of clinical mastitis in dairy cows. Dr. Francoz.
Thank you very much. So, you all know that mastitis and clinical mastitis is an important disease in dairy herds. It has already reported to have a negative impact on productivity, longevity, and profitability of our dairy herds. And it is also reported to be an important cause of antimicrobial use. In organic herds, because of their certification, alternative treatments must be instituted first. Additionally, in the context of the prudent use of antimicrobials in conventional herds, other treatments than antibiotics are also required. Numerous non-antimicrobial treatments have already been reported to be used in conventional as well as organic dairy herds. They can be divided in two different types of treatments, alternative treatments, as well as non-antimicrobial conventional treatments. However, to our knowledge, no data on the efficacy have already been collected in a coherent way and formally evaluated. For this reason, the objective of this systematic review was to identify non-antimicrobial therapies for the treatment of clinical mastitis in lactating dairy cows that have demonstrating efficacy. So all clinical trials, randomized and non-randomized clinical trials, all observational study, experimental challenges, are all types of studies that were included in the review. However, in cases of experimental challenges to be included in the study, the treatment must have been instituted after the onset of the clinical signs. Lactating dairy cows were the participant of interest in this review. Consequently, all tropical breeds and all non-ruminant or other ruminant species were excluded from the review. All non-antimicrobial treatments for clinical mastitis during lactation were reviewed, whatever the route of administration. However, to be included in the review, the treatment must have been instituted alone, meaning without antibiotic. The outcome of interest in this review was the resolution of clinical signs as well as the resolution of intramammary infection, meaning clinical cure rate and bacteriological cure rate, as well as the impact of the treatment of milk production. A Boolean strategy was consequently developed with help of a librarian in order to identify relevant records published since 1970 in English or in French in 3 different databases, CAB-Abstract, PubMed, and Web of Science. All searches were performed the same day, June 3rd, 2014. Additionally, the list of the reference of the included study were also reviewed in order to find additional records. Selection and data extraction of the study were performed independently by 3 different reviewers. Additionally, the evaluation of risk of bias of the study was performed independently by 3 different reviewers using the Cochrane collaboration tool for systematic review of intervention. Finally, post-hoc statistical analysis power of the included study was performed using a threshold of alpha threshold of 0.05 using a Fisher exact text for 2 proportion. So, for the result. Here you have a figure that represents the flow diagram of the review process. So following the initial database search, 3,078 records were identified. After removing the duplicates and the first screening of title and abstract, 167 records were retained, and after full assessment for eligibility, 35 manuscripts were included. Following screening of the record, the references of these first 35 manuscripts, an additional 4 manuscripts were identified. So finally, we had 39 studies included in the review. The 39th manuscript corresponded to 41 trials, 22 clinical trials, 13 endotoxin challenging experimental model, and 5 bacterial challenges experimental models, and finally 1 optional observational study. And as you can see, most of the alternative treatment have been evaluated in clinical trials, and on the opposite, all the studies that evaluated the efficacy of anti-inflammatory drugs have only been evaluated in experimental models. These figures summarize the risk of bias of the included study and the classification as low, unclear, or high risk of bias. All trials are at least one potential source of bias rated as high or unclear. And it is important to keep in mind at this point that the unclear category was not an intermediate category between the low risk and the high risk categories, but a category that we use when we were not able to categorize the risk as low or as high. For example, 56 of the study have a random sequence resolution risk classified as unclear because there were no mention of the randomization in the study, or no mention of how the randomization was performed in the study. The source of bias most frequently rated as high risk were related to blinding of participant and personnel, blinding of outcome assessment, and finally, selective reporting. Other potential important sources of bias were also detected in 93% of the trials. Here, this table summarizes the results for the 5 clinical trials that evaluated the efficacy of homeopathy. So you have the homeopathic treatment in the first column after the type of the study, the outcomes evaluated in the study, so a clinical cure rate, bacteriological cure rate, or a mix of a clinical and bacteriological cure rate, the control group that were present in the trials, the issues, it is meaning the difference observed between the treatment groups, and finally the power that we have calculated based on the data available in the trials. So as you can see, 3 trials did not report differences in clinical or bacteriological cure rate in comparison with positive or negative control groups. However, as you can see on the right of the table, the study power was low, thus it is not possible to conclude on non-inferiority or non-superiority of homeopathy in comparison with control groups. Interestingly, in one study, homeopathy was reported to have higher cure rate in comparison with antibiotic treatment at one point in time, but at the same point in time, a lower bacteriological cure rate was reported. In one study, a higher clinical cure rate was observed with homeopathy, but in this trial, all calls that did not respond to the homeopathic treatment within few days were excluded, which is definitely an important bias. Finally, in one trial, homeopathy was reported to have lower clinical and bacteriological cure rate. The efficacy of probiotic intramammary administration was evaluated in 2 different clinical trials, and no differences in clinical or bacteriological cure rate in comparison with antibiotic treatment was observed. However, the study power of this study was low, so once again it is not possible to make any conclusion on non-inferiority of this treatment. And additionally, in one study, a higher somatic cell count was observed in the probiotic group at day 7 and day 14 post-treatment, and in the other one, the definition of cure is not in agreement with actual standard recommendation. 5 trials evaluated the efficacy of oxytocin injection, 2 with additional frequent milking out. Overall results show similar to lower bacteriological or clinical cure rate for oxytocin treatment with or without frequent milking out in comparison to antimicrobial treatment. When compared to no treatment, no differences were also observed. In one experimental study, oxytocin had significantly lower cure rate and bacteriological cure rate in comparison with no treatment. Once again, the study power of the 4 different clinical trials was relatively low, so no conclusion regarding non-inferiority or non-superiorities can be made. Additionally, two negative outcomes are reported in two different studies, one on one on the proportion of relapse and the other one on the pathological cure rate for some type of bacteria. 9 trials had evaluated the efficacy of 6 different biologics products. 4 trials have evaluated the efficacy of botanicals and 2 trials the efficacy of vitamins. Lower to similar clinical or bacteriological cure rate compared with antibiotics were observed. Similar clinical or bacteriological cure rate were also observed in comparison with no treatment. And for the few studies that report the effect on milk production, similar milk production were reported. However, once again, the power of this study was very low, and in some studies it was not possible to evaluate the power of the study. So once again, no conclusion can be drawn. Finally, 4 different non-steroidal anti-inflammatory drugs and 3 different corticosteroids were evaluated in 14 trials. In the 12 trials on endotoxin-induced models, the most constant finding was a decrease in body temperature, with the exception in 3 trials. There were no effect on meal modification, with the exception of 2 trials, and no effect on meal production, with the exception of 1 trial. In the 2 E. coli challenge models, there were no effect on clinical resolution and bacteriological count. However, in one of the trials, a higher milk production was observed. So in conclusion, no evidence-based recommendation can be given for the use of alternative or non-antimicrobial conventional treatment in the treatment of clinical mastitis. However, based on the actual data on probiotics and oxytocin with or without frequent milking out should not probably be recommended. And to date, homeopathy has not demonstrated efficacy. So definitively, there is a huge need for well-designed randomized clinical trials in order to evaluate further the efficacy of non-antimicrobial treatment and alternative treatment. And perhaps one also of the recommendations should be that a primary evaluation of a new antibiotic treatment was performed in experimental trials. And finally, in order to minimize bias, reporting clinical trials following the consult statement is strongly recommended. I would like to acknowledge Huguette Mallet for help in the Boolean strategy and also the funding of the project, so Agri-Innovation Program of Agriculture and Agri-Food Canada, and as well our partners, Dairy Farmers of Canada and Valacta. So if you have any question.
Any questions from the floor? I would like to ask David, how can we solve the problem of research funding in the area of complementary medicine? The multinationals are not all that keen on funding research on homeopathy or herbs or acupuncture. So where do we get the money to do good trials? We all accept we need good trials.
I think that Dr. Karaman told us a few minutes before that there is actually one project that have a big funding on botanicals, and this project is also the first part of a big project in the evaluation in a trials for other treatment or perhaps biologics or botanicals. So the fundings will never come probably from pharmaceutics, but because of the place and the importance of organics, dairies actually in some countries, probably the government will be more able to give some money for that. It's my experience, but I don't know.
Any questions?
Yes, I have a question and a comment. First of all, I had a question. What about...
Could you wait until the microphone? Okay.
Have you seen any correlation between the quality of a study and the quality of the journal? Because what you tell us tells me that, first of all, the study was not conducted well. So there was obviously not a statistician involved in most of the studies. But I'm still surprised that these low-quality trials are under review process and then published. They should be rejected if they have such a lousy quality. So again, just it was a comment, but a question: is there a correlation between the quality of the journal and the quality of a trial?
It's a big question of debate, and I have a slide that I removed because of question of time, just to figure out in which kind of journal we found the different manuscripts, and in fact, most of the manuscripts included in the review were found in peer-reviewed journals, and some of them are very good, but have a high impact factors. And in some, the one with the wrong definition from bacteriological care, for example, is probably a journal that you can say it's a gold journal. So I think that there is no correlation between the quality and it's because it is the big question of the peer review process. So it's another debate, I think.
Thank you very much.